Hey everybody, we've got another heart today. This is number 1074 in our collection, and the heart would have sat roughly in the chest like this. Anterior surface coming out towards the screen, posterior surface towards the turntable, head or superior up here, legs are inferior here, left over here, and right over here. Let's start off as we usually do, which is by trying to identify at least externally what is the right atrial appendage. And here we find an appendage that is triangular in shape, pyramidal in shape, or broad-based, consistent with, at least externally, a right atrial appendage. So why don't we go ahead and open up the heart there. And when we do that, we do find pectinate muscles that spill outside the confines of the appendage all throughout, consistent with a morphologic right atrium. And right away, we can appreciate the oval fossa here. And we can see that there are already fenestrations in the oval fossa here. And then there is a larger defect here as well. So we do have an oval fossa interatrial communication, and you can see that there's multiple defects within the oval fossa itself, one being larger than the other fenestrations. Then we also find this other hole here, and this is outside the confines of the oval fossa and is consistent with a vestibular interatrial communication, or vestibular ASD, which is also a true atrial septal defect. It is morphologically, embryologically, developmentally different from the oval fossa defect and has to do with the vestibular spine and the mesenchymal cap, and is also developmentally different from a primum atrial septal defect. And remember, the primary atrial septal defect isn't found or noted in the absence of an atrioventricular septal defect, which is not noted here. So an oval fossa atrial septal defect and a vestibular atrial septal defect as well. And then here is the mouth of the coronary sinus. Here is the tendon of Totaro. Here is the right-sided atrioventricular junction. And we know that those three structures form the triangle of Koch. So mouth of the coronary sinus, tendon of Totaro, right-sided atrioventricular junction form the triangle of Koch. And at the apex is where we would expect to find the AV node, or the atrioventricular node. So here is where we would expect the atrioventricular node to live in this heart. The right-sided atrioventricular junction is guarded by a 3-leaflet valve that does have direct connections to the ventricular septum, consistent with a morphologic tricuspid valve. This ventricle appears to have coarse trabeculations and does have a septomarginal trabeculation, aka a moderator band, all consistent with the morphologic right ventricle. As we get up into the right ventricular outflow tract, we do find an arterial valve, or a semilunar valve, that has 3 leaflets, 1, 2, 3, with 3 sinuses, 1, 2, 3, and no coronary arteries arising from these sinuses, all consistent with a morphologic pulmonary valve. Now, with the arterial valves, both the pulmonary and the aortic valve, important to note that there isn't a true round or oval annulus. The fibrous valvar leaflets have these myocardial triangles that are interposed between them, such that the true annulus, which is that border between the fibrous tissue and the myocardial tissue, is actually kind of crown-shaped. The round or oval annulus that we create by echo, what we call the basal ring, is actually a man-made structure, but that's not to say it's not helpful. Just to point out that it's not a true anatomic structure. So here's the pulmonary valve, and note that it's all supported by muscle. Here's the pulmonary trunk, and then we can see the right pulmonary artery diving back here. Now let's go to the back of this heart. Here's the posterior surface of this heart. Here is the left atrial appendage, and we can see nicely that the pectinate muscles are all confined within the appendage itself. Let's go ahead and open up the left atrium. And when we look at this left atrium, here we see the oval fossa, and here's that larger atrial septal defect in the oval fossa. And you can see the borders of the oval fossa nicely from the left atrial aspect. And then remote from that is this atrial septal defect here, which is the vestibular atrial septal defect. All right, so once again, here's the oval fossa, here's the oval fossa defect and some of the fenestrations, and then removed from it and outside the confines of the oval fossa is another atrial septal defect. This is that vestibular ASD that we also noted from the right side. And notice its proximity to the mitral valve here. We do see the left atrioventricular junction here. It is guarded by a atrioventricular valve with two leaflets, 1, 2. This atrioventricular valve does not have direct connections to the ventricular septum, consistent with the morphologic mitral valve. And the ventricle that it opens up into has fine crisscross trabeculations consistent with the morphologic left ventricle. As we noted from the right, the ventricular septum is intact. As we come up into the left ventricular outflow tract here, we can see the second arterial or semilunar valve. Here's a coronary artery arising from one of the sinuses. There are 3 leaflets to this valve, 3 sinuses, 1, 2, 3. And there is fibrous continuity with the mitral valve, all consistent with a morphologic aortic valve. And once again, the semilunar valves or the arterial valves have a true crown-like annulus because of the myocardial triangles that interpose between the fibrous valvar leaflets. Thus, the true annulus of an arterial valve is crown-shaped, and the round or oval structure we create clinically is, in fact, what we call the basal ring. Here's the ascending aorta, which gives rise to the transverse arch, and then the descending aorta. So once again, from the right side, we have a heart that's got an oval fossa atrial septal defect here, as well as a vestibular ASD here, and here's the mouth of the coronary sinus.